Good afternoon. I'm Dr. Camara Jones, and I'm going to start our discussion this afternoon on racial discrimination in healthcare by sharing with you two stories, two allegories, to make all of us brave enough to talk about racism. The first story, Dual Reality, was based on my own real-life experience as a medical student when I was studying with some friends, because I was a very diligent medical student, and we were studying long and hard in my apartment. And it got late, and we got hungry, and I had no food in the apartment, so we decided to go into town to try to find something to eat. We walk into town, we find a restaurant, we go in, we sit down, the menus are presented, we order our food, food is served, here we are eating. So I know this is not a very elucidating image yet, because most of us have had this experience. But let me tell you, as I sat there with my friends eating, I looked across the room and I noticed a sign, and that sign was a startling revelation to me about racism. So now you're wondering, Dr. Jones, where did you go to medical school? What did that sign say? Well, let me tell you, the sign said open. So now I know I've lost most of you, but let me pull it back in. Here we are, sitting in a restaurant, eating. I look across the room, I see a sign that says open. And if I hadn't thought anything more about it, I would have assumed that other hungry people could come in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I realized that now, because of the hour, the restaurant was indeed closed. And that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come in, sit down, and eat. And that's when I understood how racism structures open, closed signs in our society. Racism structures a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even realize that there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. It is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context. Except that we got a little taste of that with Ebola, did we not? And yet those on the other side of the sign, those on the outside, are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who say, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism, it's an empowering thing. It doesn't even compel you to act, but it does equip you to act, so that if you care anything about the people on the other side of the sign, which is an if, but if you do, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, why don't you open the restaurant again? There are hungry people outside. Let them come in. You will make more money, and oh, the conversations we can have. Or maybe what you'll do is pass food through the door, or maybe you'll break the glass, or try to tear down the sign. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. And so racism structures these two or multi-sided signs. We could have a 3-hour conversation on how could people born inside the restaurant know something really about the two-sided nature of the sign. I have had a 3-hour conversation on just that question, but we don't have time for that today. What I'm going to shift to is a definition of racism, now that I've sort of given you a sense that it could exist and you not really understand the fullness of it. I'll define racism now. And when I say the word racism, I am very clear that I am talking about a system. I am not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested, but I'm talking about a system of power. And a system of doing what? It's a system of both structuring opportunity and of assigning value. And on what basis is the opportunity structured? And on what basis is the value assigned? It's based on the social interpretation of how we look, which is what we call race in this country. I will just briefly say that here in DC, you look at me, I'm clearly black. I've had the experience that in some parts of Brazil, you look at me and I'm just as clearly white. I've also experienced that in South Africa, you look at me, I'm just as clearly colored. Here I am, the same physical appearance in all three settings, but the social interpretation of that appearance would assign me to three different racial groups. And furthermore, if I were to stay in any of those settings long enough, my health outcome would probably take on that of the group to which I've been assigned, even though I'd have the same genes in all three places. So I can talk to you for an hour about what race is and what race isn't. We know that race is not in our genes. Race is the social interpretation of how one looks in our race-conscious society, and racism is the system that structures opportunity and assigns value based on that so-called race. What are the impacts of racism, you might ask? Well, when we think or talk about racism at all in this country, which is not often enough, but when we do, we understand that racism unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country. And we hardly ever talk about it because it makes some people, especially some white people, uncomfortable. And I tell you, I'm not trying to make anybody uncomfortable in this room even now as I speak. But if you feel uncomfortable, I want you to just shake it off, because it's so important for us to acknowledge the real existence of racism and its impacts. And I want to also let you know there's a third impact of racism, in addition to the unfair disadvantage or the reciprocal unfair advantage. And that is how racism saps the strength of our whole society through the waste of human resources. For example, when we as a nation do not vigorously invest in the full, excellent public education of all of our children, because some people, the blinders of racism, have made some people think there's no genius in the barrios or in the ghettos or on the reservations. You know, we can get along very well, thank you, without those kids. We know that there's genius in all of our communities, and if we were to only fully and vigorously invest in the education of that genius, we could be doing so much better as a nation, or even as a world. And I sometimes think we might already be up on Mars farming if that were a good idea, if we were to invest in all of that genius. But we wouldn't even have to go to Mars. We could be solving the problems in our communities today. Another example of how these blinders that don't value all of us equally are sapping the strength of our whole society is how we as a nation have become complacent with what I describe as the wholesale warehousing disproportionately of so many black and brown men in our prison system, as if that didn't separate us from human potential. And if you know folks who are either stuck in the prisons or cycling in and out, you know there are many geniuses that, if there had only been some other way, could be contributing quite productively to our society. In fact, of the three impacts of racism that I've shared this afternoon, I actually think that understanding how it saps the strength of the whole society is the part that we need to lift up for our nation right now. We need more media stories about that. We need more data collection if you're a researcher about that. We need more conversations around our dinner tables about how racism is sapping the strength of the whole society, so that we can have more people filled with a sense of urgency to dismantle this system and put in its place a system in which all people can know and develop to their full potentials. Before I leave this point, I just want to say one more thing. Sometimes people think it's enough to talk about unfair disadvantage. And in fact, I once had a colleague who said, Camara, take that second point off of your slide about unfair advantage. You've already talked about the disadvantage. And his comment to me belied something that I think many people believe, that there's disadvantage and then there's normal. I want to say the reason that many people believe that is because we as a nation are ahistorical. And when we think there's disadvantage and normal, it's because people do not understand that that so-called normal is built up on a whole mountain of unfair advantage. So now I'm going to shift and prepare the ground for my second story of my two stories. And this is because we're here to talk about health. And when I try to understand how racism can impact health, I have found it useful to think about racism on three levels: institutionalized, personally mediated, and internalized. So I'm going to define each of those levels, give you very quick definitions and examples, and then illustrate them with my gardener's tale allegory. Institutionalized racism is the system, if you will. It's the constellation of structures and policies, practices, norms, and values that all taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator because it's been institutionalized in our laws and customs and background norms. It shows up as inherited disadvantage or its reciprocal inherited advantage, and we see it in terms of material conditions and in terms of access to power. I do not have time to elaborate on all of these issues, but differential access by race to quality housing, equal educational opportunities, equal income, equal employment, all of these things clearly impact health. Differential access to medical facilities, including linguistic access, differential access to a clean environment, and the whole differential, well-documented differential placement of toxic dump sites or bus transfer stations in communities of color. And in terms of power, differential access to power as information could be health information or even information about our own histories. Differential access to power as resources, not just capital resources, but social networking resources and knowing somebody on the board. And differential access to power as voice in media, in government, and the like. Sometimes people will see this slide and they'll say, aha, Dr. Jones, look at your first point, your first examples there. Housing, education, employment, income. Dr. Jones, isn't that what we call social class? Why do you have that on a slide about racism? Are you talking about social class or are you talking about racism? It's an important question that many people in this room are holding right now, and you're waiting with bated breath for me to address it. So let me address it and start out by saying that first of all, we must know that it does not just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That is not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. I usually talk about 6, 7, 8, 9, 10 groups and initial historical injustices. But because of time constraints, I'm just going to talk about 2. For American Indians, the initial historical injustice was the taking of the land and the near genocide, and then the moving of the survivors to reserved lands, reservations, and then in some instances, something good was found under one reservation. Oops, you got to pick them up and move them somewhere else. We could talk about many other groups, Chinese laborers, people in Mexico who didn't cross the border crossed them. We could talk about people of African descent in this country, where the initial historical injustice was the kidnapping of West African people, and then our importation across the Atlantic with tremendous loss of life in the Middle Passage, and then for the survivors and their progeny for generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But then some people say, oh, Dr. Jones, there you go, talking about slavery. And Dr. Jones, we all know that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, don't you realize that the enslaved people were emancipated by 1865? And we're now in 2018. So that makes that 153 years ago. So Dr. Jones, all else being equal, don't you think the impacts of slavery would have washed out by now? But the key phrase in that question is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are today, present-day, contemporary structural factors that are perpetuating each of the initial historical injustices that's affected all of our groups of color. And those present-day contemporary structural factors are part and parcel of institutionalized racism. So when I'm asked, am I talking about racism or am I talking about social class, I explain that institutionalized racism explains why we even see an association between social class and race in this country. I have 5 more minutes. If you thought I was speaking quickly, then just hold on, hold on. I need to say on the institutionalized race, because my timer wasn't here, so I wasn't able to see. So, okay. Okay. So, on institutionalized racism, I need to say it can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But very important is to recognize that institutionalized racism often shows up as inaction, lack of action in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. It includes the different idea, the prejudice, the different action, the discrimination, and there are lots of examples: police brutality, physician disrespect, on and on, teacher devaluation. And like institutionalized, it can be through acts of doing as well as acts of not doing, but even more important is to recognize that personally mediated racism can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism, internalized racism, I'm defining from the point of view of members of the stigmatized races on this slide, where I define it as acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. Of course, there's a sense of entitlement that many white people walk around with, which is also a sense of internalized racism, which in the end, actually, if it's thwarted, can have detrimental health impacts, but I'm not directly dealing with it on this slide today. How could internalized racism among stigmatized people affect you? Well, self-devaluation, feeling maybe I'm really not as good as, maybe I shouldn't even try to graduate from high school. White man's ice is colder syndrome. If I'm a black person, this is a phraseology, by the way, from my parents' generation. What it meant for people of color then, it still means for many of us today. So say I'm black and I need a lawyer, I might seek out a white lawyer. If I'm black and I need a doctor, I might prefer a white doctor. In fact, if my lemonade were warm, I might go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Resignation, helplessness, hopelessness turns into a lot of self-destructive health behaviors, accepting the limitations to our own full humanity of the box into which we've been placed. So in my last few minutes, I am going to tell this second story. It also is based on my own real life experience. So if you just give me that extra minute to tell you what happened in my own real life. My husband and I were newly married. We were moving to Baltimore. I was going to finish my PhD at Hopkins. We bought our first freestanding house. Cute little house, big wraparound porch with flower boxes dotted all over the porch. And we bought the house in October, not really the time to plant. But when spring came, my husband was so excited, he ran out with our marigold seeds, getting ready to decorate our cute little house. And he ran back in because he said, you know, some of the boxes have dirt in them, but some of the boxes are empty. He said, let me go to the gardening store. So he went to the gardening store and he hauls back big old bags of potting soil, and we fill up the empty boxes. And then we put equal numbers of marigold seeds in all of the boxes, and we water them all. And at this point, I'm exhausted because I'm not the gardener, so I just sit back, going to be delighted. But about 3 weeks later, I'm walking out of my front door, and as I passed the flower boxes on my porch, I literally stopped in my tracks because what I saw as I looked at the different boxes made me think that we had planted completely different species in some boxes versus others. Because some of the boxes were full of plants, and they were tall, vigorous-looking plants. And some of the boxes just had a few plants in them, and they were scrawny and scraggly-looking. And then I realized what had happened. That potting soil turned out to be rich, fertile soil, so that every single seed planted in the potting soil had sprouted. The strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. But in that old soil, that soil we found there turned out to be poor, rocky soil. So in that poor, rocky soil, the weak seed died, and even the strong seed had to struggle to make it to a middling height. So I'm going to take this image, which many of you, if you're gardeners, maybe you've composted half of your garden, you've seen this image. It's about the importance of the soil, the importance of the environment. I'm going to take that image, and now I'm going to make it a story about racism by introducing a gardener. So we have a gardener with 2 flower boxes, one which she knows to have rich, fertile soil, one which she knows to have poor rocky soil, and she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms, and some of the seed is going to produce red blossoms, and the gardener prefers red over pink. So what does she do? She takes the Red seed, puts it in the rich, fertile soil. Pink seed in the poor, rocky soil. 3 weeks later, she sees what I saw in my boxes. In the rich, fertile soil, all the red seed is sprouted, strong red seed, tall and vigorous, even the weak red seed halfway up. In the poor, rocky soil, the weak pink seed dies. Here comes the strong pink seed, struggling just to make it to a middling height. And then, in those flower boxes, those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And year after year after year after year, the same thing happens. Till finally, about 10 years later, the gardener's looking at her flower boxes, and she said, you know, I was right to prefer red over pink. So we're going to interrupt the story there very briefly to say the first part of the story is how institutionalized racism works. You have the initial historical injustice of the separation of the seed into the two types of soil, contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But let's pick this story back up to say, where is personally mediated racism in the garden? Well, the gardener's looking at red, thinking red is just beautiful, and then she looks at the pink flowers and says, oh, those pink flowers sure are scrawny and scraggly, so she plucks off the pink blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil, so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Where the red flowers are just living their lives, enjoying being red, many of them not understanding or acknowledging that they're benefiting from enriched soil. Pink flowers are looking over at red, thinking red is mighty fine, and wishing with all their hearts that they too could be red. And here come the bees. And the bees are just minding their own business, collecting nectar, but pollinating at the same time. So here comes a bee, bzz, into one of the pink flowers, and bzz, to another pink flower, and bzz, to this pink flower, and this flower's like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So the question now arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we can go over to the pink flowers and say, pink is beautiful, power to the pink. It's an important intervention, but if that's all we do, it's not going to change the situation in which the pink flowers find themselves. Or you say, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener. Or better yet, let's have a workplace multicultural workshop for the gardener. So it's all good. So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking the pink flowers? And maybe she will, and maybe she won't. But even if she does, it still won't change the situation in which they find themselves. If we really want to set things right in the garden, we need to address the institutionalized racism. We need to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for the gardener to continue segregating resources going forward. But if you do keep separate boxes, you need to enrich that poor rocky soil until it's as rich as the rich fertile soil, and when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious. So that in that intervention on the institutionalized racism, you'll also have addressed the internalized racism. Pink won't be looking over at red, thinking red is better, or wanting to be red. And you may even address a personally mediated racism. The original gardener may have to go to her grave preferring red over pink, but her children growing up seeing the flowers equally beautiful would be less likely to have that attitude. So that story was to illustrate those 3 levels of racism and to say that we have to at least address the institutionalized, the others may take care of themselves. My final slide is, who is the gardener? Because that's the question we really need to engage. The gardener, after all, is the one I gave the power to decide, the power to act, control of resources, which are the elements of self-determination. Who is the gardener in our context? Well, government is a part of the gardener, foundations, corporations, communities to the extent they have self-determination, but whoever the gardener is, it's dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's dangerous when she's not concerned with equity, which she can look at those flower boxes and think her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. And our challenge is what to do about the gardener. To make the gardener striped or polka dotted or fuchsia. Do the pink flowers have to grow or recruit their own gardener? We can have lots of discussion about this story. Thank you very much for listening to me. Thank you.
Ladies and gentlemen, please welcome Sinsi Hernádez-Cancio.
Thank you so much. That was awesome.
Okay, this one.
Just for you. So, wow, huh? Wasn't that incredibly amazing? I really do want to thank, from the bottom of my heart, Dr. Jones. You have been an inspiration for me for many years. I think the first time I heard of the Gardner story in person was, I don't know, maybe 5 or 6 years ago. And it's been a dream for me to have you come here and share that with our Health Action Network, and I'm so glad that we were finally able to do that. One of the things that I wanted to talk about was how important it is for us to be having this conversation at this point in time with everything that has been happening politically and culturally and socially in this country, and connecting it directly with what we're struggling with in healthcare. I can tell you that this story especially, I hadn't heard of the closed sign story before. We had talked about this. And that was so important for me to listen to, because it made me make more sense about the work we're doing, but also more sense about things that have happened in my own life. So for example, I think the first time that I had a concept that there was a closed door situation with healthcare, I was 4 years old. My father was an intern at a hospital in Massachusetts, straight off the airplane, Eastern, back then Eastern Airlines existed, straight off the airplane, working in an emergency room, and he got really frustrated because he realized that for some reason, the Puerto Ricans living there were never seen by actual doctors. They were seen by the students. And he had the audacity to ask his very white attending, why are we doing this? And what was stunning is that the attending looked at this Puerto Rican doctor in the eye and said, well, these are the ones we practice on. And I remember being 4 years old and hearing my father come home from work furious and upset and angry talking about this story. And I was only 4. And it still lives in my heart. And it still informs every day what I do here at Families USA. And then I started thinking also about, apart from that, one-on-one racism that was happening, this doctor's a gardener for the ER, right? That even when my father went back to Puerto Rico, where people want to say that there is no racism in Latin America, but please, that's another conversation. But it certainly is still happening. It didn't matter that my father wasn't racist, in the sense that while he was perfectly willing to take payment for medical services in the form of a dozen eggs, or a chicken, or even once a really, really scrawny horse, or just a promise that next time your air conditioner breaks down, doctor, I'll come and fix it. When it came to what the pharmacy needed, what the ER needed, what the specialist needed, or the surgeon, they needed cold, hard cash. And because of this institutional racism we're talking about the differing opportunity for income, that continued to be a huge challenge and a huge frustration for him till the day that he died, that there was only so much he could do to improve the health of his patients. So today we're going to have an extraordinary plenary that, thanks to Camara, we have, I think, a very wonderful introduction to this incredibly important issue. And we're very, very excited that today one of the things that we're going to do is talk about the NPR, RWJ, Robert Wood Johnson Foundation, Harvard School of Public Health survey that was recently conducted about discrimination in America. And in particular, there were 2 questions about discrimination in America. And first I have to say, it was a historical study because it asked people their own experience of discrimination. It wasn't like, they did ask, what do you think about discrimination? But it was really different in that it asked people their own experience of discrimination and, them and their family. And it had two very important questions about healthcare. And in some of the workshops earlier today, you might have heard reference to some of these data. But one of the things we're going to do today is taking advantage of our cool survey anywhere facility that we have right now. We want to ask you those two questions about healthcare and discrimination. Are you ready? Take your phones out. Question number one. Do you believe you have ever personally experienced discrimination because of your race or ethnicity when going to a doctor or health clinic? And to be clear, the survey also asked Caucasians if they felt they had been discriminated against, right? So answer the question. I'm not sure how much time I should be giving you guys to deal with the technology. Okay, we have about a quarter versus 3/4. Dr. Williams, remember that, right? For your.
Well.
Here's the second question. Have you ever avoided going to the doctor or seeking health care for you or other than your family out of concern that you would be discriminated against or treated poorly because of your race or ethnicity? So this is that you actually needed to get care and didn't, because it was better to stay sick than to be subjected to humiliation and discrimination and racism. Okay, we have about 13%. Remember that for. So right now what I want to do is introduce one of the foremost experts on racism and healthcare and the effect of racism on health. We're very pleased to introduce Dr. David Williams from the Florence Sprague, I don't even know how to pronounce that, Sprague, Norman and Laura Smart Norman Professor of Public Health at the Harvard T.H. Chan School of Public Health, and has been working closely with this survey to disseminate some of that information. And we are very, very happy that he's here today to share his expertise and share more of this data with you. Thank you.
I'm going to stand close to Camara so I get some inspiration from her. Great friend and colleague for a long time. So what I want to do is to tell you a little bit about the survey and its findings, but also to set them into a larger context that we need to learn lessons from and think of how we can make a difference to improve outcomes. So this new national data on the levels of discrimination in the United States. This is discrimination at work. And individuals were asked if they had been personally discriminated in the workplace when applying for jobs, and you can see the numbers. Almost 1 in 5 whites, 56% of African Americans, 1/3 of Latinos, about 1/3 of Native Americans, and slightly less than 1/3 of Asian Americans reported they had been discriminated against when applying for jobs. What about are you discriminated against when being paid equally or considered for promotion? Again, you can see over half of African Americans and 1/3 of Latinos and Native Americans and 1/4 of Asians reported those experiences. So these experiences of discrimination in the area of work are in fact very common. If we look at the questions in that survey on discrimination in interacting with the police and the legal system, you or your family member unfairly stopped or treated by the police or unfairly treated by the courts. Again, these things do happen among whites, but it's 6 and 7% for those two indicators. For African Americans unfairly treated by the police, it's 60%, and approximately 1/3 among Latinos and Native Americans and 12% of Asians. You can see 45% of African Americans also report being unfairly treated by the courts. So again, the discrimination experiences are in fact very common. What's the impact of these experiences on the willingness of community members to reach out for help? And this is one of the really important contributions of this survey. It asks people, because of these experiences, what do you do? And this is the percent of Americans who reported they avoid calling the police when in need because they are concerned that they might be discriminated against. And you see 31% of African Americans, 17% of Latinos, 33% of Native Americans, sorry, I got those numbers flicked slightly, 8% of Asian Americans compared to 2% of whites. So that discrimination is actually consequential for Americans not seeking help when they have the need for it. Housing discrimination was another area in which questions were asked. Have you been personally discriminated against when seeking housing? Again, you can see the numbers quite high, 45% of African Americans, 31% of Latinos, 17% of Native Americans, 25% of Asian Americans, compared to 5% of whites reported discrimination in housing. Again, what are the consequences of this discrimination in housing? This is the percentage of Americans who report they considered moving or relocating because they have experienced discrimination where they live. So it's absolutely consequential even for the choices that individuals make. And again, you can see those numbers. Discrimination in medical care. You just asked that question, and you can see that the numbers here are slightly higher than the numbers in this audience. Personally discriminated against when going to a doctor or health clinic, 32% of African Americans, 1 in 5 Latinos, 1 in 4 Native Americans, 13% of Asian Americans, compared to 5% of whites, report experiences like that. And the second question that you were asked, have you ever avoided seeking medical care for yourself or your family member out of concern that you would be discriminated against? Again, we can see some numbers here that were higher than in this audience. 22% of African Americans, 17% of Latinos, 15% of Native Americans, 9% of Asian Americans, 3% of whites. One of the striking benefits of this poll as well was the fact that it oversampled populations that we don't know as much about, and so it has given us a much clearer glimpse of discrimination against Native Americans, for example, in national data for the United States compared to other groups. These self-reports of discrimination, someone could say, but that's just people's reports. How do we even know that is true? I want to make the point that they're consistent with other scientific evidence of the pervasiveness of discrimination in a broad range of domains of American society. We have high-quality scientific evidence. Much of the best evidence comes from what are called audit studies. In an audit study, you hold everything identical. The only thing you vary is the race. So let me tell you about a classic audit study, one in which a researcher sent 2 African Americans, 2 white Americans, and 2 Latinos, gave them identical resumes and sent them to apply for entry-level jobs in New York City. The resumes were identical, but for one of the males in each racial group, he indicated on his resume that he was out on parole and had served an 18-month prison sentence for cocaine possession. So one of the 2 had a criminal record. What this study found was, in the face of identical resumes, it was either for the white male with the criminal record to get a call back for a job, 17%, than the Latino male or the African-American male whose record was clean. The resumes were identical. And it's just an example of the persistence of discrimination in American society. At least some of the experiences of discrimination that individuals encounter, they are aware of. And the question is, what are the consequences for these experiences, and how do they play out for individuals? In 2003, the Institute of Medicine, National Academy of Medicine, we call it today, published a report called Unequal Treatment. The report was done in response to a request from the United States Congress, which asked the National Academy of Medicine to answer the question, when patients go into healthcare contexts in the United States, does your race or ethnicity determine the quality or intensity of care that you receive? And what this report found was across virtually every therapeutic intervention, from the most simple to the most complicated, Blacks, Latinos, and other minorities receive poorer quality care and less intensive care than whites. Let me give you one example to make this concrete. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient comes into the UCLA emergency department with a long bone fracture, that's medical speak, for a broken bone in the arm or legs, does your ethnicity determine whether you get pain medication or not? And Dr. Todd looked at every white patient and every Latino patient treated by UCLA in the prior year with a long bone fracture, and found 55% of Latino patients with a broken bone in the arm or leg had not received pain medication, compared to 26% of non-Hispanic whites. Dr. Todd was a good researcher. He said, confounding, it's something else. So he statistically adjusted whether the patient spoke English or not, whether they got injured on the job or not, how long they spent in the ER, what time they showed up in the ER, how severe was the fracture. And after statistically adjusting for every conceivable alternative explanation, the single biggest predictor of whether a patient got pain medication was the patient being Latino, and statistically adjusting for everything, Latinos were 7.5 times less likely to get pain medication than a white patient. How on earth do we make sense of that? Researchers for 30 years have been studying a phenomenon that they call unconscious or unthinking discrimination based on negative stereotypes. That if you, based on your socialization, hold a negative stereotype of a group, and you meet someone from that group, it's automatic and it's unconscious. You will treat that person differently without any intent or typically any awareness on your part. I usually tell my students that I am a prejudiced person. I am a prejudiced person, I believe, because I like to think of myself as a normal human being. And if you are a normal human being, you are most probably prejudiced. I didn't say you are racially prejudiced, because race is only one basis of stigmatization in our society, but every society, every group has in-groups and out-groups. And if you hold negative beliefs about fat people, about gay people, about women, about old people, these same fundamental processes occur that you will treat individuals differently. That is, you will discriminate against them without your conscious awareness. The good news is there's the divine solution, I call it. Professor Devine from the University of Wisconsin at Madison has identified and put together in one program a number of strategies that have shown to be effective in reducing implicit bias and helping you be successful to maintain this over the long term. One of the key factors I would mention in passing is called individuation. All of us, we process the complex cognitive information we face every day by putting things into categories. And the problem comes up if some of the social categories we have negative beliefs about based on our socialization, based on what we were taught about groups as we were being raised. Individuation says you will resist the temptation to see people, as we do in American society, research shows, when we meet someone, we notice their age, their race, and their gender. Those are the three things we first note about someone, and we note that in 1/3 of the time it takes to blink our eye, and we make a judgment about that person, and we'll treat them based on that judgment. Individuation says, I'll take time to treat this person as an individual and try to understand the uniqueness of that individual. So discrimination affects health because it affects the quality of care that individuals receive in the United States. Experiences of discrimination, these personally mediated experiences that Dr. Jones just talked about, are a source of toxic stress. I developed a measure of discrimination some time ago, multiple measures, but one of them is called the Everyday Discrimination Scale, that captures just the little indignities that people face on a daily basis. Being treated with less courtesy, being treated with less respect, receiving poorer service than others, people acting as if they think you are not smart. Just to illustrate the power of discrimination in shaping health outcomes, I want to share with you the work of Dr. Tenny Lewis. At the time she did this was a faculty at Yale University. Each line on this slide is a different study that Dr. Lewis conducted, and all of the studies using the measure of everyday discrimination and looking at a broad range of health outcomes. Higher levels of everyday discrimination predicts more rapid development of coronary artery disease as measured over 5 years by the development of coronary artery calcification. Predicts higher levels of inflammation. It predicts higher levels of blood pressure. Among pregnant women who report everyday discrimination, they give birth to lower birth weight infants. Among the elderly who report everyday discrimination, there's more rapid development of the rapid decline, in cognitive function over time. A community sample, high levels of everyday discrimination, predicts poorer sleep. A study of the adult population followed over time, everyday discrimination is an independent predictor of premature death. It is literally killing individuals prematurely. And a study of African American and white women, higher levels of everyday discrimination, unrelated to subcutaneous fat, that's the abdominal fat just beneath the skin, but is a powerful predictor of visceral fat, the deep abdominal fat in between your internal organs that predicts higher risk of cardiovascular disease and other bad outcomes. This slide just illustrates the multiple ways in which discrimination of multiple types have negative effects on health. But I want to build on Dr. Jones's point and point out it's not just the interpersonal discrimination that matters. Some of the most powerful effects of discrimination, I want to give you some examples, is the institutional discrimination that matters. Here's an example of institutional discrimination. This is a study from 2012 presidential election. How long did it take for the average person to vote by race and ethnicity in the United States? And you could see whites waited to vote in that presidential election on average 12 minutes. African Americans waited 23 minutes. Latinos waited 19 minutes. Asians 15 minutes. Native Americans 13 minutes. None of this reflected the individual behavior of precinct workers. Instead, it reflected a number of institutional mechanisms and processes linked to the budgeting and space constraints that were heavily driven by geography, where you voted, and the local administrative procedures in particular places. But even though the precinct workers didn't individually discriminate, the consequences were nonetheless real, that based on your race, it determined how long you had to wait to vote in the United States. The secret sauce that drives racial inequality in America is residential segregation. And by that I include the concentration of African Americans in urban areas, as well as the forced removal and relocation of indigenous peoples. How powerful is segregation, and why does segregation matter? Because your zip code is a stronger predictor of how long and how well you live than your genetic code. Place matters profoundly because it shapes all of the opportunities that drive health in the United States, from the quality of education to the quality of employment opportunities, to whether it's easy or difficult to live a healthy life in your neighborhood, to exposure to toxic substances, to access to high-quality medical care. Place is a driver of health. How powerful are these differences as they play out in American society? Two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studied 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. One of the disturbing trends as we look to the future is the evidence of the increasing segregation of the Latino population in cities across the United States. This is one example of this trend, work I did with Dolores Acevedo Garcia, and we looked at the 100 largest metropolitan areas in the United States where children are being raised. And we looked at the opportunities that existed for children growing up in the US. And we used whites who were the worst of whites. They were the top quintile of whites who were in places where they lacked opportunity. And then we asked, what percentage of African Americans and Latinos are doing worse than the worst of white kids? 76% of all African Americans and 69% of all Latino kids in America are living in places that are worse than the worst of white kids. And in highly segregated areas, those numbers are even higher. In fact, as Dr. Jones mentioned, segregation contributes to the large racial ethnic differences in socioeconomic status that exist. This has been documented by Dr. David Cutler, a colleague, one of the country's leading economists at Harvard University. He did a national study using fancy econometric models I cannot even fully describe, but he is able to statistically show that if you could erase segregation in America, if you could eliminate it statistically, you would completely eliminate black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. And so we have these large racial differences in income in the United States, where for every dollar of household income whites receive, I've just put it in a way you can't miss it, for every dollar of income white households receive, Asian households receive $1.23. 70% of Asians are immigrants, and Asians have high levels of education. But for every dollar, and more persons contributing to household income, but for every dollar of household income, white households receive, Latino households receive 72 cents, Native American households 62 cents, and African American households 59 cents. The 59 cents figure for African Americans in 2015 is identical to the racial gap in income in 1978. You heard me right. In 1978, blacks received 59 cents for every dollar of income whites had, and in 2015, that's what they also received. And looking at differences in income, by race in income, understates the true differences in economic reserves and resources. We have to look at the differences in wealth. For every dollar of wealth that whites have in the US, blacks have 6 pennies and Latinos have 7 pennies. So these racial inequities that we see are not acts of God, are not random events. They reflect the successful implementation of institutional mechanisms of racism. I also want, before I stop, to talk about the increasing discrimination against immigrants in the United States and the consequences that have for their health. So SB 1070 was a law passed in Arizona that empowered police officers to stop anyone who looked as if they might be illegal. And I worked with a colleague, Professor Umanya Taylor, and we published this paper looking at what impact did this law have on parents of young children. And we found on these parents, we had data on them before the law and after the law. And after the law was passed, there was a reduction in seeking medical care for their children and seeking social services. And strikingly, this effect was strongest among native-born Latinos than among foreign-born Latinos. There's also evidence from the large immigration raids, the post-Phil immigration raid, the largest in US history, that found after a community experienced that raid, a year later, they were giving birth, only the Latinos, to lower birth weight infants, long-term negative effects on health. I also want to talk, before I close, about the power of the moment we are in, where there are plans to weaken the social safety net and the negative consequences that have. We can take a walk down memory lane and see what happened in the early days of the Reagan administration, where as a result of budget cuts, 500,000 people lost welfare, 1 million people were dropped from food stamps, 600,000 people lost Medicare, 250 community health centers closed across the United States, 1 million children lost reduced price meals, and the WIC program had enough funding to serve only 1/3 of those eligible. And within a year or two, we saw increases in the number of women not having prenatal care, 143% increase in anemia in pregnant women, increased incidence of low birth weight, increases in infant mortality in poor areas in 20 states, increases in preventable childhood diseases. What I'm saying is pervasive negative impacts on the population and the vulnerable population as a result of budget cuts. We need advocacy to keep and strengthen the safety net. I want to leave you with this quote from Dr. Martin Luther King. True compassion, which we all are committed to, is more than flinging a coin to a beggar. It understands that an edifice that produces beggars needs restructuring. We need to destructure and dismantle the institutional mechanisms that are producing negative effects on the health of all populations. Thank you.
Wow, that was an incredible presentation. We're very grateful that you were able to share all this information for us that I think that for some of us kind of understood instinctually and really benefited from having kind of a structured way to think through this information. What we want to do now, I'm very excited, is we have a wonderful reaction panel where we're going to talk a little bit about, given this situation, given this, there's been evidence about interpersonal and structural and institutional racism affecting health and healthcare for a while. But in light of this new survey that really reinforces what has been, presented before, what does it mean from the perspective of reforming or transforming our healthcare system, right? We are healthcare advocates here, and how do we, understanding this, it seems like a daunting, almost impossible task to be able to create a healthcare system and change our healthcare system to address such a wide variety of challenges. But at the same time, we know that there's a lot in the healthcare system that needs to be fixed. And it's not just about what has been our bread and butter, and probably your bread and butter for a long time, which is making sure more people have coverage. What this shows very clearly is that coverage, while is a necessary but insufficient characteristic or a resource in terms of addressing people's health, and especially when we're talking about the health of communities of color and other disadvantaged communities. So what we'd like to do today is get a little bit of time for reactions and insights from this very esteemed panel of hotshots that we're really grateful that were able to come and share with us today. So let me introduce really quickly, and then we're going to go straight to some questions and discussion. So first of all, we have Andrea Ducas, the Senior Program Officer of the Robert Wood Johnson Foundation. We have A.J. Jones II, Chief of Staff for the W.K. Kellogg Foundation, followed by Dr. Marshall Chin, Director of Finding Answers, Disparities Research for Change at the University of Chicago, Ed Tepporn, who is the Executive Vice President of the Asian Pacific Islander American Health Forum, longtime partner of Families USA, and we have Dr. Tekisha Everette, Executive Director of Health Equity Solutions in Connecticut, and you all already heard Camara Jones, Dr. Camara Jones. So please welcome them all and thank them for being here. So my question to Andrea is, as the Robert Wood Johnson Foundation, you've been working a lot in the last several years focusing on what you call the culture of health. Can you tell us a little bit about why the Robert Wood Johnson Foundation decided to invest resources specifically in, basically tracking down what is the experience of discrimination in America, and why that matters to your work and what you all think needs to come out of it?
Sure. So at the Robert Wood Johnson Foundation, we are working, as you just mentioned, to build a culture of health. And what that means to us is that everyone in this country has the opportunity to live the healthiest life that they possibly can. Our new CEO likes to describe the requisite to that as being everyone having a fair and just opportunity for health. And to use one of Dr. Jones's earlier metaphors, if for a substantial number of people, the door to health is closed, we don't have a fair and just opportunity for health for everybody in this country. And as you heard from Dr. Williams' presentation, and as many of you are likely aware, we actually know a lot about the role that perceived discrimination and racism has on our health. We know that it's detrimental. We know that it produces consistently poor health outcomes. But what we didn't have a really good sense of is how widespread are experiences of perceived discrimination. There's not a lot of quantitative data out there. And this study, as Dr. Williams mentioned, oversampled several populations. It allowed us to make inferences that we couldn't make before. And from my point of view, I think it really serves to demonstrate just how widespread and how systemic these problems are. So often you'll hear folks talk about discrimination and racism, and you might have a reaction like, oh, well, that's your opinion, or that's one bad apple in the healthcare system. But when you look at this data and you see that 1/3 of Black Americans have experienced or believe they've experienced discrimination within a healthcare interaction, and 1/4 of that population has actively avoided medical care because of fear of perceived discrimination, that's a big deal. And we see in other studies that we've conducted, and also through other stories, that this has a real impact on people. So in other research, for example, we asked people when they're making decisions about healthcare, when they're choosing where to go, when they're choosing which providers to see, what's most important to them? And by and large, we heard that people wanted to know they were going to see a clinician that would treat them with dignity and treat them with respect. So we know this through quantitative information. We also talked to people, and we heard stories like a woman who was on her second pregnancy. She was so excited. She walked into her doctor's office because she was ready for her first prenatal appointment, and the first thing he said to her was, "Oh, you're pregnant again, and you're still on Medicaid." And as you can imagine, she did not want to go see that provider ever again. Because what a horrible, horrible interaction in one of what are supposed to be your happiest moments. This was a woman on Medicaid, but just, a week ago, 2 weeks ago, we got to read about Serena Williams' experience during her childbirth, right? Where this is a woman who's famous. She's got a tremendous amount of wealth. She did everything she could, and yet experienced a poor health outcome that unfortunately way too many African American women in this country experience. So it's a widespread problem, and having the heft of scientific studies, I think, is very important. So we see in this data, again, the percentages of people who experience discrimination, and thinking about it from the perspective of healthcare, in addition to framing why this is so important just from a humanistic perspective, it's the right thing to do. People want to be treated with dignity. As a clinician, you take a Hippocratic oath to do no harm. You want to treat people with dignity and empathy, and most people think that they do. But at the end of the day, if significant numbers of people are reticent to seek care from you as a clinician or your institution, that's not only important from a professional standpoint or reputational standpoint, but increasingly, and I know we're going to talk about a health equity and payment and delivery system reform agenda tomorrow, it's also bad for your bottom line. So we know that people who feel disrespected by their providers are significantly less likely to trust them. And when they don't trust their providers, they're also significantly less likely to actually take their medication or adhere to a care plan, which produces worse health outcomes. And if you are increasingly financially accountable for those health outcomes, all of a sudden that takes on a more significant sense of importance. So we are very proud to have invested in this study, especially because we can actually point to solutions that we know work. And I'm excited that we're going to hear from other people today who will talk a little bit more about that. But thank you so much for this opportunity.
So basically, what the upshot of what you're saying is that a culture of discrimination is incompatible with a culture of health.
Yes.
So that's something that I think all of us can really take to heart. So AJ, I'm very excited to hear what you would have to say, because Kellogg, and I've benefited from this, from going to the many Kellogg kind of racial healing events, has been really focused on the issue of racial healing and dismantling racism for several years now. So I'm very interested in hearing how you think this kind of information will affect, especially the work that Kellogg is doing around health, which has been, maybe some of us would say, and it's arguably that not as much as they used to. Mm-hmm. Do you think that in any way this is going to modify that or change that? And what do you see as solutions for the foundation to address this incompatibility of health and discrimination?
Absolutely. Well, first of all, let me start off by saying thank you all so much for making this possible. And I am a product of the South, so before you open your mouth and give response, you give thanks. And I really want to start off by saying this. I am so grateful that we're having a conversation about health and equity, discrimination and racism, not on the side stage, but on the main stage. Thank you so much for your leadership in reference to that. My hat's off to your board chair, to Frederick, to everyone else who envisioned this possibility to be there. And I also would be remiss, you got to thank the hands that bring you to this point. Now, you can indulge me for just 2 seconds. I want to do something here. First of all, I want to thank Dr. Jones. Back in she was much younger, But back in 1999, she sat me down after a conference and said, young man, make sure you keep your voice because people want to hear it. And I am so thankful to you for that. I'm also thankful to the gentleman to my right, Dr. David Williams. You know, he has shaped me in so many different ways, both directly, but also many of his colleagues in his doctoral program have shaped me. But more importantly, his major professor, Dr. Jim House, was one of the people who envisioned at University of Michigan the need to have more minorities getting doctoral degrees so they could then train the next field. I don't know if he envisioned me being in this seat, but I'm so grateful that he envisioned someone benefiting from that decision. So thank both of you so much for that and being here today. As I listen to this conversation, I'm reminded that one of the best voices that ever spoke to the issue around discrimination and truth to power was Sojourner Truth. In 1967, she rose up on this day as the first black woman to address the Convention on Women about the rights of black women with the wonderful statement, "Ain't I a woman?" Yes. So I do not find this moment interesting, coincidental, or whatnot, that today women are asking that very question across society, whether it be within health, whether it be within politics, whether it be within education, whether it be within income or economic security. The validation, if you will, of who they are as a people. And that, quite frankly, is where we get to this question around race and the impact of equity as relates to the healthcare system. When I think about the conversation that was had today, I'm reminded that systems only produce what they are designed to produce. And so for all intents and purposes, if you have designed a system that effectively produces ill outcomes for a subset of the population, that system will only do what it's instructed to produce. Therefore, we have to think more deeply about the policy changes that have to be made to change systems. Let me be clear. I said policy changes, not program. We can't program our way out of racism. We can't program our way out of discrimination. We can't program our way out of the historical battles that we've been fighting. That is policy change, my friends. And I was in this session just earlier today, and I was speaking about the fact that as we push on the levers of policy, whether it be at the state level, local level, or federal level, let us not forget that the majority of the policy that's been written on healthcare in the last decade hasn't been written by legislators, it's been written by judicial and court structures. And today, my friends, we're in a very unique battle around those conversations. Whether it be right now before the Supreme Court, there's a question on what should be the rights of entitlement under the Individual Disabilities Education Act in terms of what does a locality owe to a student, if you will, in reference to these things. Or more importantly, there's a question before the Supreme Court on what should be the responsibility or indemnity or immunity, if you will, a police officer should have when they use excessive force. That's before the Supreme Court right now. And as we think about how those questions have impacts on the day-to-day operations of how race moves through different parts of society, it is incumbent upon us as the Kellogg Foundation to say that we must think about how do we shift both narrative and also how do we shift systems and involve. We, as you know, like many others, have spent a large amount of time putting money into systems and services, recognizing that we got to make sure that we have people have services and opportunities. But we recognize that we were often giving them more access to a system that wasn't treating them well in the first place. So are we really thinking about how we change the parameters and the frames? And so one of the things we locked in on, if you will, was the need to be able to pull systems apart and think very deeply about the leadership of these systems. How do we create structures that think more deeply, not about how do we train health professionals, but how do we train systems to validate and value, if you will, individuals whom which they treat, and then push policy along those lines. So your reimbursement is not about how many people you push through the system, it's about how well those people in the system are able to push forward in life. It's a different way of thinking about how we orient the way we do our money and how we orient the way we do our policy change. The second piece, and I have to say this, is the fact that philanthropy is now fully embracing the reality that we have to do policy. Now, I know that sounds crazy and those kind of things, but I can honestly tell you that in a lot of philanthropic circles, we speak about policy, but we often seesaw around it, right? Because there's a dynamic. We have, obviously, tax-orientated dynamics that inhibit our ability as individual foundations to be directly involved. But that does not inhibit our ability to be able to spur the organizations necessary to be involved. And thinking much more deeply about how we orient, if you will, and bring both technical assistance, structural assistance, and I will say this, operational support.
Yeah, thank you.
Right? Because at the end of the day, if we're not building these organizations and giving them operating capital to be able to hire the people, to be able to structure the organizations necessary to move the change, then we will be sitting here another 20 years from now. Camara Jones will still be young, but we'll be sitting here another 20 years from now. I'll be gray. And we'll be talking about, we know we had that great idea way back when. The last piece, as I say, is this. One of the things that we've talked very deeply about in the foundation is making sure that as our moving around racial equity and racial healing takes place, that we push that out into the local levels. So currently right now, many of you may know, we launched something called the Truth, Racial Healing and Transformation Process. That is in 14 cities right now. We're looking to scale that further. And that basically is us giving monies to localities to effectively come together across different structures and think about what policy changes they need to make in order to make their society and their communities much more equitable. Now that, if you will, is a radical question because it requires for us all to come to some sense of agreement on what the truth is. Now this, my friend, is a painful reality, and we came across some of this in discussions about what exactly the Confederacy stood for. And I would argue to you, if we can't get to a sense of common understanding about what the truth is, then we will always find ourselves in loggerheads about what the solution is. Because we will not see the realities the way they should be. So we're thinking about, we're focusing a large amount of our resources, if you will, on shaping that piece. And then I'll close with this. One of the unique dynamics that we have seen is that across your organizations, everybody has all of these very rich and expansive networks. But the extent to which that they have been organized in such a way to be collaborative versus competitive. Let me say that. To be organized in a way to be collaborative versus competitive has been to our loss. And so one of the things that we as philanthropy must be responsible for doing is collaborating among philanthropic organizations to make sure we're not creating competition unnecessarily so that the networks in which that are moving can actually move in a collaborative and creative and thoughtful process. We believe that by doing that, that will shift the health systems in many ways. And the last piece, I'm sorry, one more piece if I can. The last piece. I raised this earlier in the last session that I was in. So today in this Congress, 71% of this Congress has been there less than 10 years. 53% of the Senate has been there less than 1.5 terms. 64.8% of all of the local elected officials have been there less than 8 years. So if you think about what the last 10 years have been about around healthcare, it's been around one thing, how to tear things down. And we need to be about the business of how do we build things, not how do we tear things down. And so part of what we've been funding and been investing in is the idea of educating legislators and also decision makers on how best to build a healthcare system versus falling under the traps of how do we tear a system down. Thank you so much.
So thank you so much for shifting the conversation into systems change, because that's the direction that we want to go in this conversation. And I want to get to brass tacks with Dr. Chin, because he's been working for many years on a project called Finding Answers, which is actually trying to find out and evaluate what are the kinds of interventions and models that actually will improve racial and ethnic health disparities. So I'd be really interested, and with excellent work with the National Equality Forum, dealing with issues around measurement. So I would love to hear from you what your reaction to the information that's been shared today is, and what you think are the pathways for the policy change that will create that structural change that we're all talking about.
Well, thanks, Sinsi. I'll talk a little bit about the healthcare survey results and then shift mostly into sort of solutions and where we go next. So if you think about those two questions, I'd like to offer in some ways both an affirmation of those results and then a word of caution. The affirmation is that these are our patients' lived experiences. It's the reality. And as Andrea mentioned, when patients experience discrimination or they experience bias, it breeds mistrust, it breeds pessimism, and it's really a setup for bad health outcomes. So it's really this vicious cycle, the downward spiral. And so it's a wake-up call for clinicians and staff that we need to deliver more sensitive, culturally competent care. It's a wake-up call for administrators and leaders of clinics and hospitals and health plans that they need to make equity truly a priority and direct the resources to really work on solutions as opposed to lip service. The caution, though, is that as powerful as these data are and as powerful as the stories are, sometimes it devolves down to, well, if we could just make that clinician or that office staff person more culturally competent, we have it solved. Mm-hmm. And I think cultural competency is great, that it's helpful. It may even be a prerequisite to improving health outcomes. But we know, and the research evidence shows, that many health outcomes cannot be improved with cultural competency alone. And it's because of what Camara and David said, that there are such hard, big, important, systematic, structural drivers of disparities that unless those are addressed, and AJ mentioned the same thing, we're not going to get there. So I teach a lot of medical students, and we'll teach in the course for the first year students right when they come into the school about disparities. And they get the bias part right away. They get the access to care part right away also. And as Sinsi said, Families USA, that's been the mantra in terms of coverage and access, clearly important. What the students have a harder time getting initially are the systematic drivers. The idea that the way we have set up our healthcare system, as AJ said, leads to specific results which aren't good results. So for example, our healthcare system as a whole is dismal in addressing social determinants of health. Community health workers, another interest of Families USA, most places it's not a form of reimbursement for health workers. That's one example. So AJ mentioned that philanthropy has come into policy. So I had my sort of aha moment regarding advocacy maybe a couple years ago. I tend to be a technical, work within the system kind of guy. I'm not the guy that's in the streets marching with the bullhorn, although I did march in the March on Science in Washington a year ago. Yeah. But 2 years ago, I'm from Chicago, and so this was the height of the Black Lives Matter movement. Laquan McDonald, you remember that name, young African-American man, shot in cold blood, videotaped. And so within Chicago as well as nationally, this brought light to the issues of police brutality and inequities in criminal justice in ways that hadn't happened before. And so I saw the power of that, even though that wasn't necessarily natural to me. And I think that's what we need here in healthcare, and it's been missing. Frankly, I'll give you another story. That 3 months ago, we had a Robert Johnson Foundation meeting, the program Andrea, program officer for Finding Answers, solving disparities through payment and delivery system reform. And we had diverse stakeholders there. One of the common themes or conclusions was, as a whole, locally and nationally, the group that is not at the table for this are the patient and consumer advocacy groups. And we know that systems are powerful. Payment is powerful. Money talks. The way performance is measured talks. The way we transform systems is a powerful driver. Consumer and patient advocacy groups, frankly, have not been at the table. And that's one reason why I'm so excited that Families USA is getting into the space with this new Health Equity Task Force for delivery and payment system reform. That, frankly, we know a lot about how to improve care. That a lot of it's local, that we got to look at in your own local context, the specific needs of your individual patients, your specific context, and then address each of those barriers. And oftentimes it takes multiple different aspects: improving clinician-patient encounters, improving the way your clinic and hospital and healthcare organization are organized, improving the partnerships with community organizations to address things like social determinants of health. We also know that money matters. Even for the most mission-driven organizations like federal qualified health centers, there's only so much they can do unless the way that care is delivered is supported to specifically improve equity and is rewarded and incentivized. And so, I think for everyone here, probably a key message is that it's critical that everyone here gets into this space. I know that this may be the most natural thing for people, that access and insurance may be what people are comfortable with. But money talks, payment is so powerful, systems talks, performance metrics, this is what drives behavior. And healthcare provider organizations, the hospital associations, the health plans, they are there and you are not there right now. And unless you're there, it's going to be the perpetuation of the current system. But it's a tremendous opportunity now, the time is right, and I applaud Families USA for getting into this space.
Thank you so much. So I'm really glad you brought up the issue of the lack of a consumer voice in the conversations, very important conversations, which are all about distribution of resources and power, right? That are happening right now to transform our healthcare system from a volume-based system to a value-based system. You know, we had a debate yesterday in a little gathering about what does value really mean, and what does it mean if you are somebody situated in, you know, the pink box as opposed to somebody situated in the red flower box, right? And you know, I think there are a few people here, we could probably count them in one hand, of organizations that have been trying to engage as a consumer voice in those spaces. And even in those circumstances, it's very clear that they are, you know, not representative of the communities of color and those who are in most need of the structural change. I think one exception of that is the Asian Pacific Islander Health Forum that has, you know, made efforts to get into that space, in part because they have some really great alumni and consultants like Ignatius Bao, who I think is here, who can support those efforts. So why don't you, I would like to hear more about how the Health Forum came to this understanding that they had to go beyond the typical, the usual, let's get coverage for everybody, let's get language access, which is something else as a health forum, you know, immigrant access, to really trying to engage in the conversation about systems transformation.
Great. Thanks, Sinsi. And on behalf of the Health Forum's President and CEO, Kathy Cochin, and the rest of the Health Forum, we really appreciate Families USA for the invitation to be part of this panel. The Health Forum, for those of you who are unfamiliar with us, we are a national health justice organization whose mission is focused on improving health and well-being for Asian American, Native Hawaiians, and Pacific Islanders in the US and its affiliated jurisdictions. And we envision a world where all people share responsibility and take action to ensure healthy and vibrant communities for current and future generations. When I think about this study that we were asked to also comment on, I have deep appreciation for the work that RWJF, that Harvard, and the NPR did to better understand the experiences of discrimination, not just for Asians, but for communities across the country. I was on a panel about a week ago where I think myself and my fellow panelists who represented the different reports that were generated expressed that we weren't surprised that our communities have experienced discrimination, but I did also share that for me personally, as an Asian American, I was surprised that the findings weren't higher in Asian American communities based on my own personal experiences, based on what I see in the country around me, and based on the stories that our community partners from across the US have shared with us. And so I had to think and reflect, what is the narrative that exists in this country around Asian Americans, Native Hawaiians, and Pacific Islanders that we have to interpret these findings through? And so I want to share with you three narratives in particular. The first narrative is that of being a perpetual foreigner, where for those of us in the Asian American community and perhaps in many other immigrant communities, it doesn't matter how long we personally or our families or communities have lived here in the US, we're never fully seen as Americans. We're always seen as others. We're seen as not belonging. And a real example of that, case in point, is I bet that every single Asian American, Native Hawaiian, Pacific Islander who is in this room has been asked the question, where are you from? Which is then promptly followed with the question, but where are you really from? As I think about this moment in time that we live in, I recall statistics from one of our sister organizations, South Asian Americans Leading Together, SALT, that there has been a 58% increase in reported hate crimes against South Asians, Middle Easterns, and Muslims. And so I think that if I were an immigrant and I was responding to a phone call that I got randomly for someone, would I feel comfortable sharing my true experiences or my true opinions about whether or not I was discriminated against? And that's not a call out on the methodology, but it is an invitation for us to think about other opportunities to explore what discrimination looks like and how it gets experienced. The second narrative is around invisibility. And so whether it's in the media, which has a long-standing practice of casting white actors in Asian and Pacific Islander and Native Hawaiian roles, or whether it's discussions at national, local, or state levels, where priorities and attention to Asian American, Native Hawaiian, Pacific Islander communities are often not meaningfully included because of the size of our communities. There is this experience of invisibility that we have. And if you look at foundation funding, Asian Americans and Pacific Islanders in Philanthropy released a study where for the past 25 years, less than 0.3% of foundation funding investments has reached Asian American, Native Hawaiian, Pacific Islander communities. To me, that is discrimination and that is invisibility. And the final narrative is that of the model minority myth. And what that myth is that universally all Asian Americans, Native Hawaiians, and Pacific Islanders are well educated, that we're wealthy, and that we're healthy. And this is a dangerous myth because it's a false narrative, and it makes it that much harder to bring resources to those parts of our communities that are truly struggling and that are truly vulnerable. It's also a dangerous narrative because it is used as a wedge to pit Asian Americans against other racial ethnic communities. It's important to remember that there's 50 different ethnic groups that speak 100 different languages and dialects that constitute this politically constructed term of Asian American, Native Hawaiian, and Pacific Islander. And what happens when you aggregate data for our communities together is the experience of larger subgroups within our community overshadow the realities and the difficulties that are experienced by smaller, perhaps more newly arrived populations in our community. Just to give you some examples, 15.5% of the US population lives in poverty, 12.6 when you aggregate for Asian American, 18.1 when you aggregate for Native Hawaiian Pacific Islander. But when you disaggregate the data by specific ethnic group, we see that the reality ranges from actually 7.9 to 40.6 of certain communities live in poverty. There's a model minority myth that we are well educated, but when you look at levels of those who have less than high school education. For the total US population, it's 13.3%. Aggregated for Asians, it's 13.5, 11.9 for Native Hawaiian Pacific Islanders. But when you disaggregate the data, the reality emerges that it's actually 4.4 up to 35.1% of certain communities that have less than a high school education. So I'll try to wrap up, Sinsi. So what now? There's a couple of different areas. I think that there's opportunities for more research and data. I'm personally interested in what additional research on discrimination our communities might reveal when we look and dive deeper into disaggregated data. I'm curious what the discrimination looks like across immigrant experiences. I'm interested and curious about what discrimination looks like for those of us who are multiracial or who belong to multiple oppressed communities. And I also am curious about how discrimination looks when you factor in a person's ability to speak English. In Asian American communities, 1 out of 3 Asian Americans has limited English proficiency, and that has a distinctive impact on the way that we navigate our daily lives. As we look into coverage and access, it's important to remember that for Asian Americans and Native Hawaiian Pacific Islanders, the uninsured rate was 15.1% prior to the ACA for Asian Americans and 14.5% for Native Hawaiian Pacific Islanders. But there was wide variation there too, that ranged from 7% for Japanese to 24% among Koreans and 23% for Bhutanese and Pakistani. So that's why data disaggregation is so important. It's why it's been a long-standing priority for the Health Forum. Since your original question was beyond coverage and access, at the Health Forum, we have been interested in looking at issues related to social determinants of health as we look at how we can be part of policy systems and environmental changes at the local, national, and state level. And we've had the benefit of having CDC funding previously to engage 15 communities across the country. And what they told us was before we reached out to them, their local and state health departments never contacted them. They never involved them. And while there are community trails that might have existed, the signs weren't in Asian languages. While there were community gardens, the food that was grown in those gardens weren't necessarily the fruits and vegetables that our communities ate. And so I think there's opportunity for us to continue to think about how we meaningfully include Asian Americans, Native Hawaiians, and Pacific Islanders. And in closing, in that vein, like AJ, I grew up in the South, and so I try to be respectful. As an Asian, I'm taught to be respectful. As an activist, I'm being called forward to speak truth to power. And so what I want to ask this room is, as you looked at the slides that were shared with you today, how many of you noticed that Native Hawaiian Pacific Islanders were completely missing from the graphs? That's invisibility. And so whether we are a research institution or a foundation or a media outlet or a government agency or a community-based organization, if we see that a community is invisible from the data and we don't say anything, then ultimately we are complicit in their invisibility and the discrimination against that community. And any effort that we have towards health justice is going to be incomplete at best and unjust at worst. Thank you.
So now moving to Tekisha, Everette, who go way back. We worked together on getting the Affordable Care Act passed way before I was at Families USA. And please be here tomorrow for lunch because she's one of our she's one of our Consumer Health Advocate of the Year awardees. But Tekisha went from working for many years at the federal level to going and working deep in a state. And that's a different perspective. And in particular, you're in Connecticut, a state that has an active kind of SIM program going on that decided to prioritize health equity. And you went there to lead an organization that was created to focus on that job. So we would like to hear from you what your response is to this data, how you think it applies or not to the context that you work in, and what do you see as solutions? This is something I'm sure that especially our audience will be very interested in, since so many of you are state advocates. What do you see as solutions and actions that a state advocate can take to address some of these challenges?
Sure, thank you, Sinsi. So I don't know if you realize this, but I am the third Southerner on the stage. So I too have to say a couple of gratitudes and thank yous at the beginning of my reaction. First, I want to first thank the Connecticut Health Foundation, who is the primary funder and the brain behind Health Equity Solutions. AJ mentioned the need for philanthropy or the beginnings of philanthropy to be thinking about policy and how they do that differently. And I will openly say to anybody who knows me, the only thing that could have moved me out of Maryland, the DC area, was an opportunity that centered, focused, and really connected health equity and policy together and systems change. So I'm very thankful to the foundation for this opportunity. I'm thankful to be sitting next to Dr. Camara Jones, who, when I talk to you a little bit about the work that we're doing in Connecticut, we must acknowledge that we often use and refer to her work at the Gardener's Tale and trying to make sure that people understand the connection. We do a lot of focus on structural racism. I'm a sociologist, so I'm a macro sociologist at that. So I acknowledge the interpersonal part, but I really focus in on the fact that we have institutionalized structural racism that has existed, and we are not here today by accident, but by design. And lastly, I'd like to say thank you to Dr. Williams, RWJ, and NPR, because this new research validates and shows what we already know, and that's this. Discrimination and prejudice and racism exists in our society, and health is no different. It's not as if health is some entity or something that exists outside of our society, and therefore we should think that there isn't a problem with institutionalized racism within it. So this is an opportunity for us to begin to think differently about how do we address that? How do we move forward in our society about that? And I have recently come to the conclusion that I fail in telling people openly that I think the root cause to all of these ills is the privilege and the disenfranchisement and the discrimination that we fundamentally have supported in our society and have never really dealt with and don't want to deal with and shy away from. So what's really interesting about doing this work is I moved to Connecticut to do it. Let me tell you a little secret about Connecticut in case you don't know. It's 80% white. It's over 80% white. And what's really cool about it being over 80% white is when you unpack the data and look at the numbers, you actually have what I call the statistical misfortune of some cities and towns. There's 169 cities and towns and no county government in Connecticut. For those who don't know, for my state people, you get what this means. But when you unpack that, you actually have cities and towns within Connecticut where there may only be 5 people of color total in the entire town. So people in Connecticut in some places have had the grave misfortune of not even really having to deal with interpersonal racism in their own mind. They think that we don't have that problem, that that's not an issue. But then you start to unpack and look at some of the policy decisions and things that happen within our state. You have a state capital that is overrepresented it's over-concentrated in poverty, first of all, Hartford, and I can really break down a whole lot of things about Hartford, but we'll just go to the high level. Over-representation of poverty, over-representation of people of color. But you also have in Connecticut, right next to Hartford, and this is the important piece of it, West Hartford, which is where I live. And if people don't understand history and connection to things, West Hartford had one of the first racial covenants in our society, in our country. So when you look at that point and saying historically West Hartford had one of the first racial covenants in our society, and you look at our educational system right now, and the fact that you could live West Hartford and Hartford, the line is this close to each other, and on one side of that line, you have an education system that's far inferior to the one on the other side of that line. But in addition to that, health, you have a 10-year life expectancy gap, and you live this close to each other. You begin to understand that history connects this together, that institutional discrimination and racism structurally connects this together. And we're beginning to have the conversations in Connecticut to really unpack that and understand that it's no one's fault today that this is happening, unless you hear what we tell you today and you do nothing about it, because then it's your fault.
Woo!
So we start with education and outreach and making sure that people understand and can define what structural racism means. What does that look like? What does it mean to have privileged people for so long and have unprivileged people for so long and have made people invisible for so long that we now need to do something different? And now that we know what that something different is, how do we get comfortable in the skin of uncomfortableness and really pushing forward and figuring out what do we do? So a part of what we do is this. One, we recognize that programs, in my opinion, are fabulous and great, but they fill the gaps the policies created. So if you're not focusing on what policy is driving you to need that program, then we're not going to make real change. If a program exists, really asking yourself, what is existing institutionally within our state policy, within our institutional policy that is driving the need for us to do this thing? And how do we fix and correct that? How do we do that collaboratively? One of the things we're beginning to do is go in and talking to people really small first to get them to see how your practices foster inequality and inequity, and how you can actually change those, and unpacking where they come from. So we've worked hard around community health workers because we do believe that we have to deal with the total person and what's happening inside in the places that they live. But we're also now working on race and ethnic data. And this is the last point I'm going to make because I see the clock is ticking. We're working actively to standardize how we collect racial, ethnic, and language data in our state, how we report it so that it's actually publicly available, disaggregated, and de-identified, so that there are third-party researchers and people who can hold us accountable to what we're doing in the state and actually can tell us what our problems are. But lastly, we're trying to expand the definition of race and ethnicity. Connecticut has a wonderful, diverse population, though I did say we're over 80% white. The people of color who live in there are a wonderful, diverse population. We have people from the Caribbean. We have Southeast Asians we have a wonderful Cambodian, Laotian contingent of people who their unique issues in terms of health and how they interplay in that are being missed and masked in the aggregated data that we collect. So that's something we're actively doing. So if you're looking for solutions, go back home and figure out, do you actually have the information you need to address the policies your state needs to when it comes to health, and what you can do to change that, and then how you can actively help your state government, your local government, start to drive interventions towards the people who need it most. One of the things that I've already said in my programs, fill the gaps of policies, but the other thing is we are unapologetically race forward in my organization, and my board supports that. And the reason we're unapologetically race forward is this. We fundamentally believe that if we can take care of the inequities in our healthcare system for the least of these, the people who are experiencing these the worst, and I mean that to say if you take the intersection of anything, low income, LGBTQ, and then layer race, they are fundamentally that person who is Black, gay, and poor is getting worse care and has the worst outcome than anybody else. And if we can fix this broken system for them, if we can make it work for them, that rises the tide. So we are really actively working on that, and I encourage people to take this report, take this data, and really figure out locally how you can start to go into that policy change and system change work at home. Thank you.
So I had a grand master plan that we would now have a discussion and maybe even take questions, but we would need a whole other day of conference, I think, to be able to do that. And we have to call up Frederick Isasi because he has a very, very special announcement to make that addresses this challenge and what Families USA, with many partners that are in the room, is determined to create.
Hi, guys. I think I'll stand right here next to Sinsi, if that's okay, Sinsi. So I just wanted to say, to begin with, that I'm so incredibly proud of this project. It's something that is near and dear to my heart. As some of you guys have heard me talk about, I have done a lot of work in payment delivery reform in my career. I've done work from the federal level when I was working in the Senate. And then I went to work with a lot of provider organizations, a lot of CEOs of health systems and medical societies and payers. And what I saw was that health equity is not in the discussion. In fact, it's the exact opposite. And I know I'm saying something that many of you know, but when you actually watch it in action, it really overwhelms you. The incentives that we are creating as we try to transform the healthcare system are actually making things worse in many cases for the people who are the most disadvantaged in our society. Because guess what? When you look at the way in which we risk adjust our value metrics, when you look at the way in which we are trying to get providers to hit certain targets, the people with the most complex problems are the ones who are going to score the worst. And so this idea, which is an idea that was at Families before I got here, Sinsi has been championing it now for many years, is so very, very important. And so I'm so proud to announce that we are launching a new task force that is focused on health equity and payment and delivery reform. And what's really important about this task force is that we believe it is so critical. It's going to be race and ethnic forward. We're focusing the task force on race and ethnic disparities, okay? And it's also going to be representative. We want to find the leaders in this country who represent the communities that we're trying to help. And so I'm so very proud of the work of Sinsi and all of the folks here and other folks we're about to call out who've been working on this. I do want to say something. It's not by accident, guys. I am, for folks who don't know this, I'm Cuban, 100% Cuban. I grew up in the most Latin Cuban family you can possibly imagine. Absolutely. I have a bunch of crazy, Cuban tios and tias and primos and primas and everything. And I grew up in North Carolina. And I know what it means to be the other in a room. I actually used to work about 25 years ago as a translator in an emergency department, level 1 trauma center in North Carolina. And I sat there with the financial counselors telling me to tell a Mexican family who'd come in with a child who needed a spinal tap because they weren't sure if the little baby, a 3-month-old baby, might have meningitis, that if they didn't pay something, they couldn't get seen. And I said to them in Spanish, she's telling me to tell you that if you don't pay something, you can't get seen, but that's against the law. And they have to see you. So anyway, And it's just one small example of how pervasive this is. So anyway, I'm really proud of this work. I'm really proud of Sinsi. I'm really proud of Ellen and Elliot, wherever you guys are. You guys have done a phenomenal job. I'd like to call out the people who are on this task force, who are amazing people. I've only been able, and it's a sad part of this job, my job, I've only been able to participate a little bit in the work, and the group is amazing. Every time they speak, I feel like I learned something deep and profound, so it's a real joy. Let me call you. Please stand up as I call your name, so that the whole conference can see who you are. So the first person I'd like to call up is James Albino from Atlas Research. Where are you, James? Okay. Charlie Alfaro. Charlie and I go way back. Where are you, Charlie? From the Southwest Center for Health Innovation. Okay. Ignatius Bao. There we go. Yay, Ignatius. Please stay standing. Stay standing. Anne-Marie Benitez from the National Latina Institute for Reproductive Health. Where are you? Regina Benjamin, former U.S. Surgeon General, and now I'm going to kill this, but the Bayou Battery Rural Health Clinic in Louisiana. Where are you? Regina? They were all here yesterday, so. Joe Betancourt from the Disparities Solution Center in Boston. Joe, it's great to have you here. Marshall Chin, Finding Answers, Disparities Research for Change. Ben Avsno and Ed Tepporn from the Asian and Pacific Islander American Health Forum. Here we go. Sarah DeGia from the California Pan-Ethnic Health Network. Sarah, where are you? Daniel Dawes, the Force of Nature from the Health Equity Leadership and Exchange Network. Great to see you, Daniel. Tekisha Everette from Health Equity Solutions. Tekisha, every time you say something, I learn something. Seriously. Wanda Hernandez, the Health Connect One. Marjorie Innocente from the NAACP. Marjorie. Barbara Konblau from the Coalition of Disability and Health Equity. Barbara. Stephen Lopez from Unidos US. Stephen, where are you? It's great to have you, Stephen. Deborah Riddick from the Public Policy and Community Engagement Consultant. Hi, Deborah. And then Alberto Gonzalez from Community Catalyst, a great partner in all of this work. Hey, Alberto. And then we have several other members who were not able to be here today. We have Stacy Boland from the National Indian Health Board. We have Niamanako Brown from the National Urban League, and Isaiah Wilson from the National Black Justice Coalition. So it is with great pride and pleasure I announce this coalition, and I want to give them one last big round of applause. Well done, Kathy.
This is just the beginning. We want very much to partner with as many of you who are interested in this issue. I hope, especially after hearing the words today, that you get more engaged in this conversation. Please reach out to us. The idea is that from this task, we're going to build a much broader coalition so that all of our communities can benefit from this effort. So thank you very much. And now we can all go eat and drink.
All right, Sinsi's right. So how did you like day one of Health Action 2018? All right, so we're going to be going to the Columbia rooms right next door where you will have the reception that Community Catalyst and Families USA are putting on. And I understand that there is mac and cheese, so get ready.